Sanjay, thank you very much for asking me to come and speak to you at Homerton. Actually, it's kind of comical that we're talking about MGB because the last time I was here, I met Robert Rutledge in the coffee room.
Oh, is it?
And one of our trainees came up to speak to me, and he thought he was coming up to speak to him and got most miffed. Anyway, that's by the by. Tips, tricks, and learning. I'm going to declare Sunderland does get support from Medtronics to run a course on this. Ideal technique. We think it is. It's got one joint. It means you've got reduced leak rates, reduced bleeding. You don't handle the tissue as much. There's only potential for an internal hernia in one site, but it does happen. Hello?
Yes.
Sorry, it's the wife.
Yes.
Not telling you.
That's why.
Not telling you, son. Right, quiet. We've got to catch up time. Right, decreased operative time. That certainly is appealing to the hospitals. We do have lower morbidity because there's one anastomosis, and we do get similar, if not better, weight loss than Roux-en-Y's. And there are multiple studies to show that. Standardise your protocol. Best tip ever. Keep to it. Position your patient the same way all the time. Your entry technique, use that all the time. Staple guns, use the same staple guns all the time. And if you're going to suture or staple the internal hernias, do it the same way all the time. I've just changed, and I've got a patient on the table at the moment who's having an internal hernia repair. Orogastric tubes, same size. Remember to move them around and trust your anaesthetist to have them out of the stomach when you're stapling. That's the position we use. Other people use beach chairs, but this is based on the French cholecystectomy position, but tilted at a 30-degree angle. You're going to have to change your port sites. If you use these positions for your standard Roux-en-Y gastric bypass, you have to elevate them or drop them. Probably more likely drop them because you're going to be doing a joint that's lower down. The left-hand port's kind of important, and that tends to go a bit more up towards the right upper quadrant. And that's because your left hand's in there, it's got the staple gun. You're too medial, it's difficult to get into the lesser sac. Too lateral, stitching's difficult. Too high, stitching's difficult. And if it's too low, you're not going to get the right angle on the first firing. Colleague of mine, Kamal Marwar, who everybody knows, did a paper on this because we had a problem in the past and showed you how to staple and the points of difficulties. Well worth looking this up if you want to try and work out how to do the pouch properly. The point of entry into the lesser sac should be on the horizontal part. Do dig out the angle of his because once you've cleared the front of that, it's so much easier to get the firing in from the back. This is the first firing. Look for the crow's foot, go distal to it. You'll be surprised at how much thinner the lesser curve and the fat tissue there is compared with when you're doing a Roux-en-Y gastric bypass. But it can be tricky, and if that's the case, approach it from the greater curve. Make a hole in the greater omentum, look underneath the stomach from that side, and you will see the window develop. As you get more experienced at dissecting on the lesser curve, that's less likely to be needed. The pouch, long and narrow. 16 to 20 centimetres is reckoned to be the length that you want. Your second 45 staple should be parallel to the greater curve. Don't go too close to it, and I'll show you why later. And the staple line on the pouch should be parallel to the lesser curve and uniform. Make the anterior and posterior walls as even as you possibly can, otherwise your tube's going to twist. Always look in the crotch for those loose staples. Imagine a knife trying to push a staple through tissue that it's trying to staple together. That's going to tear, that's going to make it bleed, and it could make it leak. When you get up to the top, angle away from the incisure. And then we've got another colleague of ours, Will Carr, and his law is it's always going to take one more cartridge than you think. Nice even tube on the orogastric, not tight. If I remember rightly, Rutledge used to use a 32 French gauge. We use a 36 and we're loose on it. We don't think it has to be that tight. And there's Carr's law. But you can see that we've kept away from the, wrong one, that one. We have kept away from the esophagus. So there is some tissue there, and that's to reduce the risk of ischemia. Prepare the distal pouch where you're going to make the anastomosis. Clear it of vessels and fat on the back of it. And the gastrostomy will be on the dependent part. Now, you can make that hole various ways. You can get the anaesthetist to put the bougie down and pierce into the lumen of that. You can cut off the angle of the first two staples. I prefer to cut through the staple line because then I know I must have cut mucosa. I must be in the lumen because you can end up doing a submucosal staple anastomosis. And always tidy up those staples that are hanging around. And there's where we would try to go. This is probably Schlock because he does perforate onto the tube and does an anterior one. But where a staple line crosses a staple line, that's going to be an area of weakness. So you want to try and take that out of your equation. Momentum is usually free and mobile unless you've had previous surgery. You don't usually need to divide it, and it will roll. So start from the left side, just roll it up, and the first thing you'll almost certainly come across is the DJ flexure, and that's easy to start counting from. As you've heard this morning, limb lengths are debatable. We more or less now do 150 centimetres. And that's because we've looked at our weight loss figures between 150 and 200, and they're the same. The problem is that a longer, what would be a BP limb, is going to increase your malabsorption and potentially more side effects from that. Rotate the bar clockwise when you're counting it. Try not to get the assistant to hold it. We've had leaks because of that. Be aware of tension, and if there's a pull going on, try tilting the table, take the angle off. That might help. Alternatively, look south, because you may well find there's adhesions holding the bar. Anastomosis. From the left upper quadrant port, use your right hand. Aim the gun with its anvil, normally in the jejunum, to the right crus when you've stuck it into the tube. Minimize the stretch in the small bowel, because if you're pushing hard, you're liable to skewer the back wall of the jejunum. Bring the pouch down onto it. It should be long enough that it'll easily get there. As I've said before, don't staple across a staple line, and don't staple in the bougie. Speak to your anaesthetist, get the tube pulled back out of the way. Many of us have got I've stapled in the bougie tie. I'd like to think that that club is getting fewer and fewer members. So this is one of the earlier ones where we actually have got the cartridge inside the small bowel. It's now turned around, so I now have the anvil in the small bowel. But you can see that it's aiming to the right crus. So it's almost an angular anastomosis at the back wall. Internal hernias. We used to say it never happens in one anastomosis procedures. It does. It's not as common, but it does still happen. Use the same technique that you use for closing internal hernia sites in your Roux-en-Y. We use staples when we've got them. But try and do them in 2 layers. It gives you much more reliability of closure. You cannot close the Peterson, because that's what it is. You can reduce it, you can raise the height of it, you can make it more difficult for the bowel to go across. But as you've already seen, internal hernias can still happen. The Danielle stitch. I've started doing this, and it's basically just tacking the end of the gastric tube, usually onto the antrum or onto the greater omentum, to try and stop any twist developing. It does work, and it makes sense. So, learning curve. Operative time is shorter, 1 less anastomosis. Rutledge claims 37.5 minutes. I take 55. It's still going down. Learning curve, Lee wrote a paper in 2012, reckons that about 30 fewer cases are required to do this procedure. Certainly if you're doing room-wide gastric bypasses, this should be a walk in the park. Personal observation, it's good for male fat distribution. If you've got that central obese patient, this is the operation for them. It gives you a nice long tube. The short mesentery on the small bowel doesn't cause trouble. And you can get a nice anastomosis without any tension. You do avoid the spleen, because in this patient group, we used to do sleeves. And I absolutely sweated buckets when I got up towards the spleen, cutting the greater curve and doing the gastrosplenic ligament. Usually it bled. And finally, it's easy to convert. If you get into problems, you can get out of there. Now, you've seen this before as well. The point about this is, jejunum is the first 8 feet, or 240 odd centimeters. That's where protein's mainly absorbed. So if you're doing a 2 meter PP limb, that's where you're actually joining, almost on the ilium. And no wonder you can get problems with protein malabsorption. We did a survey of surgeons on this as well. And the important part about that one was this, where we looked at all the papers and the fixed length of the BP limb. And less than 150, you don't get malabsorption. Above that, you start getting it. Don't go looking for problems. So the longer that we totally bypass, the more likely you are to get mineral, vitamin, element malnutrition. And we haven't found that you actually get better weight loss. We touched on bile reflux. Long, narrow tubes supposed to be good for this. You can put in a Caballero suture if you're doing an OAGB. Avoid patients with large hiatus hernia. We are very reluctant to do the one anastomosis in patients with large hiatus hernias or severe reflux. There is a small incidence of bile reflux, but if this is your option for the patient where you worry about doing a Roux-en-Y, maybe you can accept that you're going to have bile reflux after a loop, warning the patient you may have to do a diversion later on when they're thinner and when it's easier to do. Marginal ulcers, you get them in all. Smokers are the problem. Most of them are asymptomatic, actually. It could be down to the sutures that you use. Try again to stop them smoking, and also use anti-secreting medications in addition to PPIs. Some of our learning points, I mentioned, make sure that your second staple line is parallel to the greater curve. This patient, it got too close, so we had to go back to theatre so that we could join the antrum up onto the body of the stomach. Tunnelling, when you do your gastrojejunectomy and actually your submucosal. She couldn't eat or drink and was worried, so she went back to theatre. We took down the anastomosis and couldn't get into the stomach. Easy cured, you just do another firing on the mucosa. This patient, this just goes to show that ulcers will perforate. You get this gas there. This man had a loop. We converted him to a Roux-en-Y after he perforated the first time. He perforated again, and I think he actually managed to perforate 3 times. He kept on smoking. This is another patient. You can see the stomach's a bit dilated. Why was that? We've got an obstruction. In actual fact, there was an adhesion down to his sigmoid colon as when it looked south. So you do get caught out. We've done a number. These are the ones that have caught us out so far. That's all I was going to say. Tips, tricks, things. Keep any questions for later.